All right, so today I'm going to talk about the evaluation of antibiotic resistance among Salmonella and Campylobacter isolates from agricultural workers in Minnesota. I just want to start off with a brief profile of Minnesota agriculture. We have about 73,000 farms that cover 26 million acres of land. We're still the #1 producer of turkeys in the country. We slipped to #3 in hogs this past year. And we have a population of about 5.5 million people, but only 6% of them live on a farm. So the MDH UMash study aims, I'm going to give you sort of the context of our large study before I go down into the antimicrobial susceptibility part of it. But we were really seeking to describe the frequency and burden of enteric zoonoses in egg workers, their families, and other people exposed to agricultural settings in Minnesota, and then to identify disease prevention interventions and help those egg workers implement them. And finally, to develop, implement, and evaluate educational campaigns to raise awareness around these issues. So some of our methods, these are the pathogens that we're interested in our study. So we're looking at Campylobacter, non-typhoidal Salmonella, Cryptosporidium parvum in particular. We've excluded the other types of Cryptosporidium, really focusing on the one that cattle would naturally carry. Shiga toxin-producing E. coli 0157 and non-0157 Shiga toxin-producing E. coli. And to give you some context, because I think we're the only folks here working in like an applied public health setting. So we are at the health department, and we only know about the people that come in through our reportable disease surveillance system. So the way we get our information is from this reportable foodborne disease surveillance, and the way that works is a person, oh, not all of this is showing up. Well, a person becomes ill, and then they get sick enough to actually go to their doctor, and that doctor has to actually think about requesting a stool sample to be tested. And if that stool sample is tested, actually gets tested and is positive for a reportable foodborne pathogen, then two things happen. The doctor sends a report to MDH Epidemiologist, which I am one of those, I'm an epidemiologist at the health department. And then the isolate or specimen is also sent to our public health lab. And those pieces of information are then combined. So we have that lab and epi data that we use together. So that's how we first hear about people being sick. And then the next thing that we do is we attempt to interview all of our cases as soon as possible using a team of graduate students that we affectionately refer to as Team Diarrhea. I was a member of Team Diarrhea at one time. And so they really go through this detailed questionnaire that includes questions about people's food history, large gatherings, restaurants, but it also asks a lot of questions about their animal contact prior to their illness. So you can see an example of the questions that we ask. If folks answer yes to 9 or 10 on this form, then the interviewer goes into a lot of detail trying to get really specific information about the type of food animal exposure that they had and where that exposure occurred. After that, I review these initial interviews, and we categorize each person into tiers. So each case is only assigned one tier and assigned to their highest risk tier, regardless of how many agriculture exposures they have. And so our highest risk tier is this tier 1, living and or working on a farm with food animals. Tier 2 exposures are people who visit a farm with food animals, and then tier 3 exposures are people visiting a public animal agriculture venue. So county fair, state fair, petting zoos, an egg skills camp are all examples of that. And then after they're categorized, we re-interview the cases using a tier-based questionnaire. So we have different questionnaires for each tier. Tier 1, the folks who are living and working on farms, are by far our most detailed and longest questionnaires. We get about a 75% rate of actually getting hold of people and enrolling them in this. Minnesotans are patient people and are willing to be interviewed multiple times, generally speaking. So after that, all of these data are entered into the Minnesota Electronic Disease Surveillance System, which is also where that initial interview gets entered. All of those data are combined, pulled out, cleaned, and then analyzed for our study. And so just giving you some results so far from that study. So overall, for our study from 2012 to 2016, we had 7,560 cases that were eligible for our study inclusion. And that includes all the Campylobacter, Salmonella, Cryptosporidium, and S-Tech 0157 and non-0157 S-Tech cases reported to the health department. Out of that 7,560, we had 23% or 1,699 cases that did report an animal agriculture exposure prior to their illness. And when we put them into our tiers, 61% fell into tier 1, 29% fell into tier 2, and then 10% fell into that tier 3 category. And this isn't directly related to antimicrobial resistance yet, but we thought it was interesting that you typically hear the most about the tier 3 cases when we have outbreaks or problems, but really the majority of our illnesses are happening on private farms. People are living, working, or visiting those farms, not going to these agritourism facilities. So another thing that we wanted to know is during the study period, what were the chances of someone living or working on a farm developing a zoonotic enteric infection compared to the general Minnesota population? And what we found is that their risk is 8 times greater than someone who does not live or work on a food animal farm. So the cumulative incidence we found was 14.7 cases per 1,000 people in our egg community compared to 1.9 cases per 1,000 people in the general population that does not live or work on a farm. Which led us to ask, what are the chances of developing an antibiotic-resistant zoonotic enteric infection? Is there any difference between the farming population, the non-farming population? So that was the next question, what got us thinking about that. And today I'm giving you very, very preliminary results to that question. So just a little bit of context too is Campylobacter and Salmonella are 2 of the top 3 causes of enteric zoonoses in our agricultural population just by sheer numbers alone. And then we also see that just more broadly at a state level. So this is our bacterial enteric pathogens reported to the health department overall over time. And you can see that Campylobacter and Salmonella are just our most commonly reported pathogens regardless of the person's background. So I'm going to give you just a little bit of a clinical picture of Campylobacter and Salmonella. For Campylobacter, the symptoms we think about are diarrhea, often bloody with a fever. Their constitutional symptoms are often severe. The duration is usually less than a week, but it can be 3 weeks in up to 20% of people. We have a hospitalization rate of about 15% and a really low case fatality rate of just 0.1%. So although people usually don't get incredibly ill, when you interview them, they always say they feel like they're going to die. They just feel totally horrible. When we think about antibiotic therapy, most patients really do not need antibiotics. It's a self-limiting infection. It can shorten the duration if it's initiated early enough. But there are some times where we really should be giving them to folks in certain high-risk patient groups like pregnant women, people who are HIV infected or severely immunocompromised in some other way. And it can also benefit people if they are one of those people with a more severe case with a high fever, bloody stools, being sick for longer than a week, or their symptoms are getting worse. When we look at Salmonella's clinical picture, we really, the common symptoms we see are diarrhea and fever that can be pretty high. That hospitalization rate is higher at 28%, and about 1 to 4% of our immunocompetent people will develop a bloodstream infection. So that risk is higher in infants, elderly, and those with a weakened immune system. And looking at focal invasive infections that end up like in the brain or bone, for example, occur in up to 10% of people with those bloodstream infections. So most patients are, again, not going to need antibiotics for a Salmonella infection. Usually it is self-limiting. It's not going to shorten the duration of their illness, and it may actually, sorry for that typo, prolong the carriage of the bacteria. But again, there are certain times when we do want to use antibiotics for these infections, and that should be given to patients at an increased risk for invasive disease, so very young, elderly, those with concurrent medical conditions or weakened immune system. And then if someone does develop a bloodstream infection, we don't really have a choice. At that point, we absolutely do need to treat them, and we need to be able to have an antibiotic that works. So why is multi-drug resistance in Salmonella important beyond just the fact that we need antibiotics that are available so we don't have a treatment failure? We have also noticed that when we have multi-drug resistant strains, there tends to be increased rates of infection, increased invasive disease. The hospitalization rates are generally higher, and higher mortality. So a little bit about how we actually go about doing this testing at the health department. So this project at MDH as part of UMass started back when UMass started in 2012. So since 2012, UMass Salmonella or Campylobacter case isolates have been tested in our public health laboratory. They use a broth microdilution to determine the minimum inhibitory concentration, which is how they determine if this bacteria is resistant or sensitive to the antibiotic. For Campylobacter isolates, they are tested for susceptibility to 9 different antibiotics, and for Salmonella isolates, they are tested for susceptibility to 12 different antibiotics. And there's also a separate thing from our UMass study where there's a sample of non-UMass case isolates that are tested every year, and that's part of the antibiogram that the health department does and has been doing for a long time. And that group is what we use as our comparison group. So these are super, super preliminary. I really want to emphasize that, that these are our initial findings. But what we're seeing is that ciprofloxacin is a common treatment for Campylobacter infections. And nalidixic acid is an indicator of being cipro-resistant. So it was interesting for us to see that with our very preliminary data that someone with an animal egg exposure prior to their Campylobacter infection is actually less likely to have a resistant infection compared to someone that does not have an animal egg exposure. However, our sort of readily accessible comparison group that I mentioned as part of that antibiogram could potentially include international travelers. And we know that international travelers are much more likely to have a resistant infection just because there's a lot of resistance globally. So our next step for this is to really go back and clean that comparison group out and make sure that if there were international travelers in that group that we remove them and then do this analysis again. Excuse me. When we look at the tetracycline, which we know is commonly used in animal feed, we do see a higher percentage of resistant infections among those with an animal agriculture exposure compared to those without an animal agriculture exposure. However, tetracycline is not an important treatment. From like a clinical perspective, it's not important for treating a Campylobacter infection in humans, but it makes sense that we would be seeing this higher rate. And then this is a comparison of our UMass cases with non-UMass cases for infection susceptibility for our Salmonella isolates from 2013 to 2015. Again, very preliminary results, but both ceftriaxone and trimethoprim sulfa are clinically important drugs in the treatment of Salmonella. They're used for those high-risk groups to treat Salmonella infections. And in our preliminary data, we do see a significant difference in resistant infections among those with an animal agriculture exposure compared to those without. And for those with a bloodstream infection, again, you would use ceftriaxone or Cipro to treat. So really the drugs of choice. So it is concerning that we are seeing more ceftriaxone resistance in our UMass cases. When we also briefly looked to see how many people had a multi-drug resistant strain, and we used 3 or more, being resistant to 3 or more antibiotics as the cutoff for this. And our overall numbers are quite low, but looking at this, there is a significant difference for folks that have an egg background compared to those that do not have an agriculture exposure. But again, that N is pretty small. So, our preliminary conclusions are that for Campylobacter, there's really not much difference in resistance rates between isolates from agriculture and non-agricultural populations. For Salmonella, isolates from agricultural populations appear to have higher rates of resistance to several clinically important antibiotics and to be multi-drug resistant than isolates from non-agricultural populations, but this is really us just sort of scratching the surface, so we need to stay tuned and have more time to really dig into the data that we have. Our lab is also still currently testing some of those isolates, so we don't have all of the data from all of the years yet. Thank you.